Mabuhay at magandang araw po sa inyong lahat. Maraming salamat po sa PMA, lalo na kay Doc Benny Atienza, sa imbitasyon na magsalita sa inyo ngayon. Special shout out to UERM Medical Alumni, especially to the class of 1986. Also to my colleagues and students at the Colleges of Medicine at MTC and at LCUP, to the officers and members of the Philippine Psychiatric Association, and finally to the officers and members as well of the San Juan Medical Society, particularly to Dr. Maricar Gonzaga. Today I have been tasked to talk to you about a very important topic, the psychosocial impact of isolation and quarantine during a pandemic, which is an overlooked and underrated issue. At some point in the past few months, an estimated 2.6 billion people, or 1/3 of the world's population, lived under some kind of lockdown or quarantine. This has been referred to as the largest psychological experiment ever conducted. Let us look at what the possible results of this quote-unquote psychological experiment could be. These are my objectives, and we will be going through them one by one. I am currently doing a study on the psychosocial impact of the pandemic on elderly Filipinos, and a colleague helped by sharing the link of the survey in her Facebook page. One of the respondents was an elderly female cousin of hers, and she posted a message about the survey. Allow me to paraphrase for the sake of clarity. This is used with the consent of the person concerned. But for me, napakalaking torture sa aking pag-iisip ang makulong sa bahay. Dati kasi pag Linggo, Sabado, kumakain kami sa labas ng pamilya ko. Now, miss na miss ko na ang mga apo ko. Sa video call na lang kami nagko-communicate. Na-miss ko rin palagi kaming nasa mall mag-asawa. Now, bawal na kami sa mall. Okay lang kasi kahit paano, nakatulong kami para hindi kumalat ang COVID sa pamamagitan ng pagkulong at pananatili sa bahay. Kalaban ng katulad naming matatanda ang sobrang kalungkutan. Now let me cite an actual clinical case. A couple of months ago, a colleague teleconsulted with me regarding his elderly mother, a widow living alone with one maid, who presented with atypical manifestations of depression, focused primarily on somatic symptomatology that started late April. His mother did not use a cell phone nor the internet and could not therefore avail of teleconsultation herself. Allow me to go through some highlights of our conversations via text messaging. I have to add that we also had voice calls via Viber. In one of his first text messages, my colleague wrote, "Hindi na kasi magawa yung usual routine. Weekly parlor, movies, small, group and religious activities, etc." I reviewed the history with him and he added, "Tingin ko nga dahil sa pandemic na ibang routine niya. Ayaw niya naman lumipat sa Cisco. Gusto niya rin nag-iisa para may magawa daw." He obtained additional information from his sister who was in contact with her mother more often, and she texted, "Mommy told me she's lonely since the lockdown started." And she added, "Dati, lumalabas kami twice or thrice weekly, watch movie, eat outside, plus shopping and attend Bible study and CCF on Sundays." There was a remarkable change in the patient's activities of daily living, and she was cooped up in her home, unable to go out and fearful to have visitors over. Since she also had a lot of anxiety complaints, I started her on a low-dose anxiolytic as a prelude to eventually initiating a low-dose antidepressant. I had additional discussions with my colleague and explained to him that the elderly are particularly vulnerable to the anxiety and depression brought about by physical isolation or distancing due to COVID-19. In his mother's case, the drastic curtailment of her means of enjoyment were aggravated by a drastic reduction as well of physical contact with loved ones. I shared my experiences with other patients and even those with my own mother, about accompanying her to Mercury Drugstore while my sister brought her to the mall, but always protected with the face mask and the face shield with frequent hand sanitation. Thus, we eventually came to these strategies as well for his mother. Pwede bang ipasyal kahit sandali sa mall? With all the protective gears para magkaroon siya ng idea about the real situation outside. And as soon as ECQ translated to GCQ, they were able to bring their mother out and she was able to resume some of her previous activities. As a result, she texted him, "May improvement na. Mag-walking ako kahapon. Sana tuloy-tuloy ng paggaling ko. God is good. Thanks for His love and faithfulness." What is the current knowledge about the psychosocial impact of isolation and quarantine? Before we proceed further, let us operationalize first a couple of important terms. First of all is isolation. It is the separation of people who have been diagnosed with a contagious disease from people who are not sick, while quarantine is the separation and restriction of movement of people who have potentially been exposed to a contagious disease to ascertain if they become unwell to reduce the risk of them infecting others. We know that physical distancing is an essential component of preventing the spread of the virus, but when applied rigidly, it would result to isolation affecting vulnerable groups, including the elderly, the medically ill, and those with mental health conditions. Let me emphasize that physical distancing does not just involve staying 1 or 2 meters away from another person. It also involves isolation and quarantine, as you can see in this poster from the WHO. So what are the issues that isolation and quarantine have brought about? One is the limitation of people's mobility, which is more distressing for those who are able and self-sufficient. Particularly affected are breadwinners or heads of families, which has resulted to feelings of inadequacy, poor self-esteem, and loss of control. Which is why a lot of people broke quarantine. They had no choice but to find ways to support themselves and their families. Another issue was in terms of healthcare. There was limited or no access to healthcare services. Almost all outpatient clinics were closed. Healthcare resources were mainly diverted to emergent care settings. Bear in mind that for many individuals, telemedicine is not accessible due to the lack of digital infrastructure and/or the attendant costs. I spoke with a 69-year-old female patient with thalassemia who told me that her greatest source of anxiety during the lockdown was that she could not see nor contact her hematologist. An interesting aspect that was noted in the Philippines was regarding going to church. The quarantine period also prevented the faithful from attending church services and observing traditional practices, especially during the Holy Week last April, thereby increasing their sense of isolation, since going to church on Sundays was frequently the only time some of them were able to go out of the house. Research has demonstrated that social connectedness and engagement with other people are important to promote well-being, but that is being directly challenged by physical distancing policies, as evidenced by the experience in Wuhan, China, which is why it is important for policymakers to consult with the service users to ensure that their needs are met. Because the experience in Wuhan, where strong lockdown restrictions, even barricades were applied, would have been our experience as well if the IATF guidelines were not changed. And because social isolation leads not just to emotional reactions, but also to physical problems as well. A study has shown that not only does social disconnection put people at greater risk of anxiety and depression, but it also puts them at heightened risk of cardiovascular, autoimmune, and neurocognitive problems. So therefore, we would have more to contend with. What are the common manifestations of distress brought about by isolation and quarantine? We all know that quarantine is often an unpleasant experience for those who undergo it. Separation from loved ones, the loss of freedom, uncertainty over disease status, and boredom can, on occasion, create dramatic effects. Suicide has been reported, substantial anger generated, and lawsuits brought following the imposition of quarantine in previous outbreaks. We'll talk a little bit more about suicide later on. In particular, quarantined healthcare workers were significantly more likely to report exhaustion, detachment from others, anxiety when dealing with febrile patients, irritability, insomnia, poor concentration and indecisiveness, deteriorating work performance, and reluctance to work or consideration of resignation and other avoidance behaviors. Acute stress disorder is common, and later post-traumatic stress symptoms among healthcare workers can be seen even 3 years later, together with depression and substance abuse. What are the pre-quarantine predictors of psychological impact or vulnerability? There were two consistent factors based on studies. First one was a positive history of mental illness, and the other was being a healthcare worker. Demographic factors such as marital status, age, education, etc., were not consistently associated with psychological outcomes. Thus, it is very critical to consider that psychiatric patients and medical frontliners are especially vulnerable to the psychosocial impact of isolation and quarantine during the COVID-19 pandemic. What are the factors that can aggravate or worsen the psychological impact already present? First would be long duration of isolation and quarantine, particularly if it is unpredictable or not time-bound. Next would be fears of getting infected or bringing the infection home to loved ones, since we are dealing with a highly contagious disease. Then, presence of frustration and boredom, especially for those who are unable to work or study from home, or those living alone away from loved ones. Next would be inadequate supplies, including food, medicine, and other basic necessities, together with the lack or poor access to digital technology. And finally, a lack of adequate, credible, or consistent information about the situation coming from reliable sources. After the quarantine period, the individual will be met by at least two major challenges. The first would be confronting a significant financial loss, particularly for those of us in a no work, no pay situation and without a regular source of income, which includes a lot of physicians in pure or primarily private practice. And second, adjusting to the demands or idiosyncrasies of the new normal, which may not necessarily be easy for a lot of us. Fortuitously, right before the lockdown, a group of Belgian researchers conducted a benchmark survey among a representative sample of the country's population in terms of how strongly they were under stress. In that survey, they saw that 32% of the population could be classified as highly resilient, represented by the teal bar at the top. Only 14% of the population indicated toxic levels of stress, represented by the bright pink bar at the top. In their more recent survey, shown at the bottom, after 2 weeks of lockdown, the teal portion has shrunk to 25% of the population. That is, the resilient population decreased from 1/3 to 1/4. The toxic or bright pink part of the population increased by 10 percentage points from 14% to almost 25%. Simply means that during the lockdown, the percentage of resilient population decreased, the percentage of the population under toxic stress increased. Quarantine experience from the previous SARS pandemic in Canada has shown that symptoms of post-traumatic stress disorder or PTSD and depression were observed in 28.9% and 31.2% of respondents respectively. In addition, longer durations of quarantine were associated with an increased prevalence of PTSD symptoms. And finally, acquaintance with or direct exposure to someone with a diagnosis of SARS was also associated with PTSD and depressive symptoms. We already mentioned about suicide earlier, but I still want to reiterate this. Social distancing interventions have been implemented to fundamentally reduce human contact. While these steps are expected to reduce the rate of new infections, the potential for adverse outcomes on suicide risk is high. The combination of physical distancing, economic stress, barriers to mental health treatment, pervasive widespread anxiety, and other factors create what has been referred to as a perfect storm for suicide mortality. And these have made it critical for all stakeholders to be cognizant of the psychosocial impact of isolation and quarantine during this pandemic. So what are the strategies that we can employ to lessen the adverse impact of isolation and quarantine during this time? Earlier, we talked about aggravating factors. Now, let us talk about mitigating factors. First would be telling people what is happening and why. We all know that information is key. People who are quarantined need to understand the situation. And by providing relevant information, this can ensure compliance with government-mandated regulations. Explain how long it will continue. The quarantine period should be as short as possible, and the duration should not be changed unless in extreme circumstances and without proper explanations to those concerned and affected. Doing meaningful activities while in quarantine. A lot of people help themselves to be able to combat frustration and boredom by doing productive activities such as enrolling in online courses. There were even those who tapped into their entrepreneurial spirit by engaging in income-generating businesses. Additional mitigating factors include providing clear communication. This would also involve effective and rapid communication, which is truly essential. And finally, ensuring basic necessities such as food, water, and medicines are available and can be provided. There are two key messages regarding the psychological underpinnings of isolation and quarantine. The first one is that most of the adverse effects of isolation and quarantine come from the imposition of a restriction of liberty, and even the perceived restriction of liberty. Thus, it is critical to obtain voluntary quarantine, which is associated with less distress and fewer long-term complications. Next, the government should emphasize the altruistic choice of self-isolating. As has been mentioned previously and also exemplified by the first case I cited, public health officials can pander to the good nature of the citizens so that they will perform isolation and quarantine without complaints. Both of these can be achieved by providing clear guidelines and more than sufficient information of the importance of these two tasks. In this day and age of digital technology, we have so many resources that we can avail of. We do realize that digital technology, particularly social media, has been partly responsible for a lot of the anxiety and depression going around, especially the fake news, misinformation, and its incessant availability. However, it has also been a boon in these difficult times because it has provided social connections to isolated individuals and also to families that are far apart via virtual messaging systems. Other resources include telemedicine platforms such as SiriusMD and Recovery Hub. And as far as crisis hotlines are concerned, we have 3 to 4 major crisis hotlines in the country right now. I'm going to mention primarily the crisis hotline of the National Center for Mental Health in Mandaluyong. The advantages to these hotlines are the following. Number 1, they are free. 2, they are confidential. 3, they are available 24/7. and they are staffed with fully trained counselors. The main drawback is that there could be a waiting period before the call can be answered due to the high volume of calls. Prior to the ECQ, the NCMH crisis hotline was averaging 400 unique calls a month last year. This June, they said it has doubled to more than 900 calls a month. Estimates are that 60% of the calls are directly COVID-19 related and about 30% are related to anxiety, according to some of their top officials. They have also upgraded the system. They are now able to accept landline to landline toll-free calls from anywhere in the country by simply dialing 1553, thus making the service more accessible now to those in need. They also have a Tele-Mental health service for frontliners and OFWs. If you need more information about free service providers, the Psychological Association of the Philippines, in their Facebook page, has provided a list of other centers offering free counseling. The list includes centers from different parts of the country. From the original list of 22 centers in April, it has now increased to 37 nationwide. Let me now share a few practical tips that most individuals can do to lessen the burden of isolation and quarantine. There are a lot, but the following are key recommendations from current guidance and research for healthcare workers supporting patients with COVID-related anxiety and quite useful as well for individual self-care. These come from the Center for Evidence-Based Medicine of the University of Oxford in England. The first is regulating exposure to COVID-related media, which we already mentioned earlier. Limit exposure to social and mass media reporting on the pandemic, and use only trusted resources to access information about COVID-19. Next is maintaining a strong social network. Connect with family and friends via telephone or the internet, and support others in the community who are isolated and alone. Third, looking after their body and avoiding unhealthy coping strategies. Take care of one's physical health, eat healthy, sleep well, and exercise regularly. Finally, focusing on the mind via self-care techniques such as stress management, meditation, and mindfulness. Let me now wrap up my presentation. In summary, we learned the extent of the problem imposed by isolation and quarantine. We have seen the manifestations of its adverse impact, and we have listed strategies to help deal with them. Let me share some parting words. The psychosocial impact of isolation and quarantine is wide-ranging, substantial, and can be long-lasting, often contentious, and therefore needs to be handled carefully. Government officials and other stakeholders should take every measure to ensure that this experience is manageable and even tolerable as much as possible for everyone concerned. There can be long-term consequences that affect not just the people quarantined, but also the healthcare system that administered the quarantine and the politicians and public health officials who mandated it. The potential benefits of mandatory quarantine need to be weighed carefully against the possible psychological costs. And knowing what the effects that isolation and quarantine can create will allow us to identify the problems and come up with solutions. Before I finally end, I'd like to remind everyone that September is World Alzheimer's Month. And with that, I'd like to end my lecture and to thank you for your kind attention. Maraming salamat po at mabuhay ang PMA.